And now we're going to introduce a friend and a board member and a renowned doctor, Dr. Anil Kapoor, if he would mind joining us. And we've got another hot topic, Dr. Kapoor, that you're going to speak on. The future of adjuvant therapy in RCC seems to be hitting all the news spots out there in the kidney cancer world. So we're really looking forward to your talk. I'll just let the audience know that Dr. Anil Kapoor is currently the Professor of Surgery, Urology, and Oncology at McMaster University, St. Joseph's Hospital in Hamilton, Ontario. Dr. Kapoor is also the current Director of the Urologic Cancer Center for Research and Innovation at St. Joseph's Hospital in Hamilton. He is the head of the Genitourinary Oncology Program at the Juravinski Cancer Center and the co-chair of the NCIC Kidney Cancer Disease Group. You're also the chair of the Kidney Cancer Research Network of Canada, which is a section or connected with Kidney Cancer Canada. We work closely together. So I will welcome you and I look forward to your talk. Thanks very much.
Thanks, Christine. Thanks, Mona. I really enjoyed the patient conversations we just saw. That was really inspiring, and it makes us want to work harder to cure kidney cancer. I think that's our goal eventually, to cure patients and prevent patients from getting their cancer back, curing it when they have metastatic disease, curing it with surgery. Those kind of talks that we just saw really are very inspirational to double our efforts to do a better job. So thank you for that. And my talk today is going to be on adjuvant therapy. And adjuvant therapy is a therapy you would get after your cancer has been resected, but there's a percentage of the cancer coming back. And how would we lessen that risk of the cancer returning? Just have to try and work my slides here. There we go. These are my disclosures for today's talk. So I'd like to start off one of the patients in my practice. This is a wonderful 61-year-old female who is a librarian. She was an ex-smoker, but otherwise had no other risk factors. She presented with some pain in her abdomen and had an ultrasound and then eventually a CT scan showing a mass in the left kidney. And it unfortunately had already spread to the lung and to the pleura. And so there was evidence of metastases on diagnosis. Just to explain some imaging, so when your oncologist or your urologist goes over your CAT scan with you, what you're looking at, if you can see my pointer, this is the liver here, this is the bowel in here, this is the chest and the heart. And this mass is in the left kidney. It's a big mass, about the size of perhaps a baseball, or a little bit larger than a baseball. It's encompassing the entire left kidney and pushing into the spleen up in here and pushing into the liver. And so this patient had non-metastatic disease. And so we're able to take her to surgery and we're able to remove that kidney. As Dr. Bunce and Dr. Tanguay talked about the techniques in surgery. We won't go into that in this lecture, but we were able to remove that mass in its entirety. And it was a large 15-centimeter mass, maybe not a baseball, but much bigger, about 15 centimeters. And it was stage T3A into the sinus. I'm going to go into what that means in a few minutes, but basically it was a third stage cancer. Dr. Bunsell showed you a picture at the beginning of his lecture, and this would be a third stage. And then the grading was a grade 3 out of 4. So when we look at these cancers, it's very important when you talk to your urologist or oncologist after the surgery, is to look at the pathology report, get a copy of your pathology report. That's really the most important piece of paper in your cancer journey to help define your risk of reoccurrence and the result of the kind of cancer that has been developed. So stage 3 is into the renal sinus, and the grading is from grade 1 to 4. And grade 3 out of 4, it means it's a higher grade cancer. Grade 1 or 2 is a lower grade cancer. We were able to take it all out though, and so most patients at that point say, it's all out. I'm happy with that, and so I'm going to go home and enjoy the rest of my day. but there is a risk of reoccurrence, and the risk of reoccurrence depending on the stage and the grade of the cancer. And this patient, their postoperative CAT scan was negative, which is wonderful. But the question is, what is her risk of reoccurrence in the next number of years, and how do we define that as doctors, and how do we explain that to our patients so we have an understanding of these risk of reoccurrence? Just some stuff you've already gone through in the previous lectures, but the incidence of kidney cancer is rising every year, and is an unmet medical need for adjuvant therapy. That is right now. We're going to talk about what therapies we can give for patients who have non-metastatic disease. The cancer has been removed, your CAT scans are clear, there's a risk of reoccurrence, and can we decrease that risk of reoccurrence by giving a drug therapy? So after surgery, 20 to 30% of patients experience relapse. The highest time for relapse is in the first few years. So many of my patients, when we have this discussion, we say after a few years, you're mainly out of danger. The highest risk of reoccurrence is in the first 2 years, but you can still have a relapse rate of up to 60% at 5 years of patients at high risk. Relapse means that the cancer has returned, unfortunately, and that does happen depending on the stage and grade of the cancer. And we've talked from the previous patients that give that discussion there, that for metastatic disease, our 5-year survival is low. Now that's changing every year and even every monthly now. We have lots of amazing new drugs that we're going to talk about in the next few lectures that can increase our cure rate to up to 15% complete responses in some of these new agents, and control rate is very, very high with these new drugs. So these are historical numbers. That the last number is an old number from 2016 actually. So our cure rate is higher, and our control rate is also higher when you develop metastatic disease. And so lots of room for optimism in the future to control metastatic disease. So back to our topic, the recurrence rates depend largely on the characteristics of the primary tumor. Larger tumors and higher grade tumors are at higher risk for developing reoccurrence after surgery. And we have to have some system to determine what that risk of reoccurrence is, to explain it to ourselves and to our patients. And there's a couple of nomograms that are all on the internet, or you can ask us to email it to you. We're happy to give you these details. One's called the SSIGN or S-sign score, which looks at mainly the size of the tumor and the grade of the tumor. And then you get a score based upon these characteristics to look at your risk of reoccurrence. And so T1 is a small tumor, less than 4 centimeters. T1A, T1B is less than 7 centimeters. T2 is over 7 centimeters. T3 is into the renal sinus or into the renal vein. And so the more advanced stage of the tumor, the higher risk for reoccurrence. Then you look at the grade of the tumor as well, and the grade of the tumor also gives you your risk of reoccurrence. And the higher grade out of it, 4 out of 4, you would get score of 3 on that. And then necrosis, that is how necrotic or dead the tissue is inside the tumor. And then you add these scores up to give you risk of reoccurrence. And your highest risk is if you have more than 6 of those categories, and the risk of reoccurrence is 31% at 5 years. But if you have none of those, your risk of reoccurrence is much lower, 97% cure rate, so less than 3%. So for these early stage tumors, T1 and low-grade tumors, the cure rate is very, very high, almost approaching 100%. It's hard to give 100% in medicine, but it's close to that for these very low-grade tumors. The most common nomogram is what we call the UISS, University of California, Los Angeles Integrating Staging System. And this is the one that I use in my practice mostly, and for many research papers, we use this one. And this goes to basically for localized disease, if you're low risk, intermediate, or high risk, and your risk of reoccurrence. So if it's a first stage tumor, your cure rate is very high, more than 90%. And if it's a high grade tumor, where it's high grade, high stage, your risk of reoccurrence is about 50%. And as urologists, we're trying to educate our urology community to really give a some more clarity to our patients about the risk of reoccurrence. I'm not sure if it's me advancing thing these slides or why they're advancing on their own here. Give me 1 second. So for high risk patients, we do need to have some clarity to patients that your risk of reoccurrence can be up to 50%, and perhaps we can give some adjuvant therapies to prevent that risk of reoccurrence and increase that 5-year disease-specific survival to higher numbers than 50%. Now, this is an important slide about the time for reoccurrence is usually in the first 3 years. And so you can see after 3 years, it plateaus in the years 4 and 5, and your risk of reoccurrence is less. And if it's going to come back, basically, it's going to come back in the first few years. And that's really the optimal time to give any sort of adjuvant therapy for kidney cancer. This is another patient profile. This is a gentleman who's 57 years of age, very busy. Did have some diabetes, hypertension, but never had any risk factors such as smoking or at his job. It just says that sometimes these things, these bad things can happen, even everyone does everything right. But there's still room for optimism with the surgery. Had a radical nephrectomy. It was a big tumor, 12 centimeters. The nodes were all negative, which is wonderful news. And so the staging, if you look at the size and the nodes and the metastases, was T3, N0, M0, and the grade of the tumor was grade 3 out of 4. So based upon the T3 and the grade 3, as per the nomogram that I showed you in the previous slides, this is considered a high-risk patient and up to 50% risk of that cancer coming back within 5 years. So many patients ask us as urologists after the surgery, what can I do, doc? What can I do to prevent that cancer from coming back? And so right now we don't have any approved adjuvant therapy, but there's new drugs coming that I'm going to talk about in the next few slides. And what you want ideally is a drug that is active on the microscopic cancer. It's not toxic. It's inexpensive, has a meaningful outcome, and used for patients at high risk for reoccurrence. And again, if it's a drug that's very toxic, or if it's a drug that may not work as well, what will be the point of taking it? Because this is ideally what we're looking for a drug that doesn't have side effects that would make life unbearable. I'm going to talk about 4 trials that are closed that many patients in Canada participated in. And I just want to give first a thank you to all the patients in Canada in kidney cancer that participated in these trials. Many of my patients and many patients of the oncologists across the country participated in the ARISER trial, the ASSURE trial, the STRAC trial, the PROTECT trial, all in Canada. And for those in the audience that did participate in these trials, a big thank you for participating. It gave us information to help future patients and future therapies. And I'm going to talk about some of the results of these trials because you participated in the trials. And I want to, so you should know what came from this. This was a trial we did offer in Hamilton and other sites in Canada, which is adjuvant weekly girentuximab. Girentuximab is an antibody following nephrectomy for high-risk kidney cancer, published in 2016. And what it showed is, unfortunately, that those patients that took the placebo versus the IV infusion did not have a better disease-free survival or overall survival compared to placebo. So based upon that, this drug is not going to be approved for an adjuvant therapy in kidney cancer because it didn't help patients live longer or prevent their cancer from coming back compared to the placebo arm. So this is unfortunately a negative trial, but gave us information for future trial development. There we go. Oh, let me see my slides there. Future trial development. And so this was a major trial called the ASSURE trial that was led by Dr. Laurie Wood and Dr. Michael Jewett in Canada. And we had sites in Ontario and across Canada and BC and Halifax for this trial. Many sites participated from Canada. And we're actually a very high recruiter for this trial internationally as a country. This is a trial where patients had their cancer removed, higher risk cancers, and they're randomized to sunitinib or Sutent versus sorafenib or Nexavar or a placebo. And again, this was a large trial of 600 patients per arm. And this unfortunately did not have an improvement in disease-free survival. Disease-free survival means this the cancer did not come back, basically disease-free time after surgery. So for sunitinib, it was 5.8 years, sorafenib 6.1 years, and placebo 6.6 years, showing no difference in disease-free survival and no difference in overall survival. So that means that patients who took these drugs didn't do better than those patients who took placebo. And so as a result of that, this led to another trial called the STREC trial, which looked at the highest risk patients randomized to sunitinib or placebo. And this was a positive trial for its primary endpoint of DFS. That is, patients who had kidney cancer that were high grade, high risk T3 cancers were randomized to these drugs. And those patients that received sunitinib lived a year longer, or had a disease-free survival longer, I should say, than a placebo by about a year. So 6.8 years versus 5.6. And to clarify this further is that means that those patients that took sunitinib, the cancer was delayed from coming back by about a year compared to placebo. This met its primary endpoint, but the downside of this study was that there was no overall survival. This is a DFS curve again, showing that the patients that had sunitinib had 6.8 years before the cancer came back versus placebo, which is 5.6 years before the cancer came back. So it delayed the onset of cancer by about a year in those patients that took the drug. But unfortunately, the overall survival was negative. The third trial that many patients in Canada participated in was the PROTECT trial, which is adjuvant pazopanib, or pazopanib was another tyrosine kinase inhibitor like sunitinib. This is called Votrient as well, and patients were randomized in this trial. And this was a negative trial for DFS, except for higher risk patients. Those patients that were at higher risk for recurrence, they also had an advantage of pazopanib versus placebo by delaying the onset of the metastases in these very high risk patients, again, T3 or grade 3 tumors. Now, none of those drugs were approved in Canada for adjuvant therapy because of the lack of overall survival. What that means is that even though we delayed the onset of the cancer coming back by about a year, patients in both arms lived the same length of life. So based upon that, it wouldn't make any sense to give those drugs to patients because they didn't live longer compared to taking the placebo arm. So that was just a review of what many patients in Canada participated in, but this is the exciting part of it, the adjuvant immunotherapy drugs. So these are the 4 trials, of which 2 of them are closed, where you had adjuvant atezolizumab, adjuvant pembrolizumab, neoadjuvant and adjuvant nivolumab, and adjuvant nivolumab and ipilimumab. So these are trials where patients are randomized to a standard of care or placebo arm versus an immunotherapy or immuno-oncology drug such as nivolumab, pembrolizumab, or atezolizumab. These are drugs that are approved currently for treating metastatic disease, but we wanted to know if they would help decrease the risk of cancer coming back in non-metastatic patients. And so we have one of these trials that have read out. And again, many patients in Canada have participated in these trials. And to thank you again for participating as we read out with these, with the results of this trial. This is the first of those 4 trials that I've read out. It's called Keynote 564, which was pembrolizumab versus placebo post-surgery as adjuvant therapy for patients at high risk for coming back, which was presented by Dr. Tony Choueiri just a few months ago at a major conference called ASCO. The way this trial was designed is, again, patients who had surgery within 12 weeks of their surgery were randomized to either pembrolizumab, 200 milligrams every 3 weeks, or placebo every 3 weeks for a year. After a year, the drug was stopped. And then we looked at the outcomes of disease-free survival. I mean, how long did it take for the cancer to come back? And was there an advantage of going on pembrolizumab versus a secondary endpoint of overall survival that would help patients live longer taking pembrolizumab versus the placebo. This was the DFS, and it's positive. So there's a lot of excitement about this in the kidney cancer community. This hazard ratio of 0.68 is excellent. The p-value is excellent. And what it showed is that the pembrolizumab did delay the onset of the cancer coming back compared to placebo. And you can see these numbers of at the 12-month was 85 versus 76%, 24 months, 77 versus 68%. And so the DFS, or the disease-free survival of the time of the cancer not being present, was higher in patients receiving pembrolizumab versus placebo. And that was very, very exciting for the oncology community. Now, what we do need, though, is to, even though the cancer doesn't come back, is that help patients live longer, and that we still have immature data. This is the interim overall survival results, hazard ratio 0.54, also exciting, but we need to have an overall survival proof that this is going to happen. Now, this may not happen for a number of years, and this is where we're asking the Health Canada and CADTH to help us get this approved for patients in Canada, because even though we don't have this overall survival, we may not have it for some time, based upon the positive PFS that we just showed here, DFS, that we would like to get this approved for patients in Canada, so that we can offer to patients at high risk for recurrence. Now, we feel that DFS as an oncology community is a good endpoint for adjuvant RCC. Overall survival is the best one, obviously, knowing that patients live longer on the drug, and taking it for a year is beneficial. And so DFS does provide a real-time assessment of the patient outcome. It is the primary goal for patients to have the cancer delayed and coming back. It's an earlier time point than overall survival in this patient population. And DFS has been approved in other tumor types such as colon cancer, breast cancer, melanoma for adjuvant therapies. So other drug disease sites, such as these diseases such as melanoma especially, adjuvant therapies have been approved based upon DFS and not overall survival. So we're hoping that this does get approved in Canada so that we can offer it to our patients. Again, just as I finish off here, the high risk patients have a 5-year recurrence rate of about 60%. So that's quite high. It means after these surgeries, high risk patients, it can come back in about half of the patients. So we need something to offer these high risk patients so that we can have higher cure rates. Metastatic RCC has a lot of morbidity. Our survival is getting better with these new drugs, but still we want cure rates for metastatic disease, and that's what we're working harder and harder to achieve. And right now there's no approved therapy, adjuvant therapy in Canada, and we really need this. We're very passionate. We want to be able to offer something to the motivated patient, the patient that will really benefit from this. In my mind, if somebody has a T3, T4 cancer, grade 4 to 4 cancer, give them an adjuvant therapy, I think would be helpful to offer them, and if they're to help them decrease the risk of the cancer coming back. Pembrolizumab is this first study. It may be a valuable adjuvant treatment. We're looking for longer term data, but I still would like to get this approved for our patients to offer to them. And the adverse events, immunotherapy drugs can have side effects for sure, and we can manage those. So that's part of the trade-off we have to look at, is what are the side effects of the immunotherapy drugs versus the advantage of preventing the cancer from coming back. Now, we had an oncology community. We came together, and I think I missed a slide there. Here it is. Dr. Pierre Karakovich, one of our uro-oncologists in Quebec, and all the kidney cancer community across the country came together for this KCRNC, or Kidney Cancer Research Network, consensus statement to look at this in 2018. And in 2018, our conclusion was that based upon the TKI drugs, which are sunitinib, pazopanib, and sorafenib, we should not offer these drugs based upon the lack of overall survival. Now we have to update this with these, as these 4 trials read out, perhaps adjuvant pembrolizumab, atezolizumab, or nivolumab may be a valuable adjuvant treatment options. And we're going to update this with more positive recommendations for adjuvant therapy. So I think I'll stop there. I hope I'm on time. And if you have any questions, I'd be glad to answer them. You can email me if you have any questions at my email address, or you can follow on Twitter. Thank you so much for your time.
Thank you so much, Dr. Kapoor. That was an excellent talk. And we do have some questions, if you don't mind me leading into them. I received one by email, and the question was, why would you use placebo? Why is it needed when you're doing that kind of clinical trial?
Now, the reason why is that we don't know if it would be beneficial or not if we didn't have a placebo. Right now, we can't compare it to an active drug because there's no active drugs in kidney cancer in the adjuvant space. Again, we have to always make sure we separate metastatic disease where cancer is already present and spread versus the adjuvant space, which is the high risk space. That's the space where patients have surgery and they're high risk for reoccurrence. And we don't have any approved therapies in Canada for that right now versus localized low risk disease. And that you don't need any adjuvant therapy in that. And so the only thing to compare it to would be a placebo because there's no approved therapy.
Okay, good answer. Thank you. I hope that answers the person's question. I have another one. If you take the adjuvant therapy, does that prevent you from receiving certain treatments later if needed?
That's a fantastic question. It does not. If the cancer did come back, if you received an adjuvant therapy, 100% we have other drugs to offer you. And we're going to go through that in the next number of lectures. But we have cabozantinib, we have nivolumab, we have many other drugs that we could offer patients who develop metastatic disease after adjuvant. What you give is still an area of research. So if you receive pembrolizumab in the adjuvant space, you probably wouldn't get that if you develop metastatic disease. But there's other drugs that, again, like a TKI, such as cabozantinib, sunitinib, pazopanib, axitinib, that we could potentially offer. So absolutely, there's other treatments we could offer if it did come back.
Okay, good. Thank you. We do have a question from a patient, and I'll just adjust it just a little bit. Maybe you could give some reassurance. This patient actually has a P2-1 G2 tumor, and they're concerned whether they maybe should be receiving this type of therapy. Is that something that somebody, like early stage like that or low risk would be receiving, or maybe you could answer that?
Absolutely. So with regards to the cancer coming back, we have guidelines for that we can also give to you through Kidney Cancer Canada.
Thank you.
If you have a T1 grade 2 tumor, your risk of reoccurrence is very, very low, less than 10%. So the cure rate's more than 90% that this cancer will not come back after this early stage tumor. In fact, there's some suggestion that you may not even need follow-up for this because it's such a low risk for reoccurrence. But just to reassure you, we do have the numbers on this, and the risk of reoccurrence after T1 G2 is less than 10%.
Okay, good. Thank you. I'm not seeing, I think this is such a new topic, and please correct me if I'm wrong. I'm understanding that there are no adjuvant therapies yet in Canada. Is that correct?
That's correct. There's no approved adjuvant therapy in Canada, but lots of excitement about coming therapies.
Okay.
So the important thing for patients to know is that if you have surgery for your kidney cancer, is get the pathology report, discuss with your urologist your risk of reoccurrence. For example, if it is a T1 grade 2 tumor, your risk of reoccurrence is less than 10%. You can not worry. We always worry once you get the word of the diagnosis of cancer, of course, but you can worry less that the cancer risk of coming back is less than 10%. But if you have a grade 3 out of 4 or a T3, then we're going to have something to offer you in the near future. Whereas right now in 2021, we have nothing to offer you yet other than stay healthy, exercise, eat well, think positive, because that really goes a long way as well.
Yeah. Yes.
And then we'll be able to offer you a drug therapy in the future. I think all 4 of those trials will be positive, and then we'll have a choice of therapies to offer you.
Excellent. I know it's kind of hard to predict the future, and there's many steps that it needs to go through for approval, but am I asking the wrong question is there kind of some indication how long it might take?
The government of Canada is a black box to all of us, right? So it's hard to know. We're hoping the next year that we'll have some positive recommendation. We've made a presentation to Health Canada on this adjuvant pembrolizumab. We've made a presentation at CADIT as well. And so hopefully with these, with the support of Kidney Cancer Canada and Bob Bick, who also works with Cancer Canada, and yourself, Christine, and patients, we're looking for patients as well, that patient stories as well, that will give to the government to help them understand that this is an unmet need. Again, this is not a Me Too drug. Right now, there are options for patients who can be offered for metastatic disease. We have a number of options, but we have nothing right now for adjuvant therapy. And when I have a patient in front of me who has a grade 4 to 4 tumor and a T4 tumor, I absolutely know that that patient is so high risk for recurrence. I would like to offer them, even if their CAT scan is negative, very, very positive and uplifting, but we really hopefully can offer them something to decrease the risk. Now, if there was already another drug out there, then we may not want to push it as much. But with nothing to offer now, I think we really need to fast track this approval.
Agreed. And I think you brought up an excellent point that in Canada, sometimes our patients aren't aware of all the steps that need to be taken, through the government and through research, that just to get a drug approved and available to patients in Canada. So you brought up an excellent point, I think. Thank you.
Our pleasure.
Thanks very much for your talk today and for joining us and supporting us.
Yeah.
As always, we're very grateful for your input.
Well, it's a pleasure. Thanks.
Okay. Take care.